In my previous installment of the Wired Practice video blogs, I raised an unconventional idea for addressing a big healthcare problem and asked you, MedPage Today readers, for comments. And wow, did I get them! More than 120, roughly 10 times the number of comments my videos typically get. Being a former engineer and numbers guy, my response was to classify the comments by category. While there weren't enough to yield a truly scientific sample, there were a sufficient number to provide a few insights. My original idea sprang from a recent study published in the Journal of the American Medical Association. The study reported a shocking majority of healthcare consumers consciously withholding medically relevant information from clinicians. Specifically, in one poll of patients, 61% admitted to being less than fully transparent with their caregivers, and in a second poll, 81% said they withheld information. The reasons the survey participants gave for withholding were as follows. They didn't want to be judged or lectured. They didn't want to hear how harmful their behavior is. They feared embarrassment. They didn't want the clinician to think they're difficult patients. And they didn't want to take up more of the clinician's time. Does this sound like intimidated patients? It sure does to me, which is why I floated a trial balloon, a hypothesis, not an evidence-backed theory, one that I knew might well draw objections. The question I posed was, if patients were on a first-name basis with all clinicians, including physicians, would this decrease their intimidation and increase their candor? The notion clearly touched a raw nerve. By my count, more than 4 dozen of the online comments on the blog expressed robust, vehement opposition. Another dozen indicated earnest skepticism. The strongest dissenters categorized the idea variously as ridiculous, shallow, superficial, naive, BS, very biased, deeply flawed, utter nonsense, a lot of baloney, the most absurd thing I've read on your website, plus my favorite, snowflakey. One even went so far as to condemn me as a, brace yourself for this, a businessman who can't do much else, so you stand at the podium and point fingers. Maybe I need an image overhaul. It must be my jacket and tie. Perhaps I should take on a more humble, down-to-earth appearance. Or maybe something more pious. Wait, won't work, I'm married. Yes, it's true that like nearly half of all physicians in the United States, I am a self-employed services provider with a staff and a payroll to meet twice a month, although I'm not sure how that corrupts my thinking any more than that of any other boss. But anyway, by far the most common objection to the idea of dropping the doctor title was about status. Nearly half the protesters said something to the effect of, I earn the right, I deserve the respect, we physicians know more than patients, and we are not patients' equals. Let's see. Doctor says we are not equals. Patient says my doctor unnerves me too much for me to tell him or her everything. Does no one else here see a possible connection? Well, at least one reader did. A commenter who did not self-identify as a physician remarked that you are not my equal viewpoint is likely picked up easily by patients. The second most common protest focused on academic credentials. Mine. 10 years of post-secondary education and 3 university degrees have amounted to my going no further than a paltry Master of Science diploma. On this basis, quite a few readers opined that an MS degree disqualifies the holder from credibly discussing this topic. This, of course, constitutes an ad hominem attack, a criticism not of an idea itself, but of the person putting forth the idea. The third most common response touched on a perceived erosion of public respect for physicians. This perception is discredited by survey after survey, which for years have shown that doctors rank consistently in the top 5 of the most respected and trusted professions nationally and worldwide, along with, you guessed it, nurses. The fourth most common response was to blame electronic health records for discouraging patients from sharing sensitive information that others might access. Echoing the speculation of physicians interviewed for a related MedPage Today article, although in neither case did anyone cite any studies. A couple of commenters also insisted that the authority conveyed by the doctor title encourages patient compliance with medication and lifestyle and rehabilitation instructions, but again without citing specific scientific evidence. So why dwell on this issue? Well, for this reason. American healthcare spending tops $3.5 trillion each year, an estimated $1 trillion more than the U.S. spent in the first 15 years of the wars in Iraq and Afghanistan. That number is 35 plus 11 zeros. Let's say, for argument's sake, that if we found a way to lessen patients' fear of disclosure, Would that not most likely increase earlier detection and more affordable treatment of certain diseases and health conditions? And if it did, hypothetically speaking, let's conjecture that this would lead to, say, a 1% reduction in our annual national health care cost, or $35 billion a year. For perspective, $35 billion is more than 6 times what the federal government now spends on cancer research every year. Is such potentially gargantuan savings not worth some heavy-duty thinking outside the proverbial box? Think of the conceivable gains not only in improved healthcare outcomes in general, but also in shifting those resources to escalating the fight against humankind's second deadliest disease by a multiple of 6. All right, maybe going to a first-name basis isn't the solution. It's certainly not the only possible solution. I only propose it as a hypothesis, not a proven theory. To be sure, there are counter-arguments. For example, one emergency room physician commented that early in his career, he introduced himself to patients by first name but later changed this habit, he said, when it became clear patients come to the ED to see a doctor and were noticeably comforted when hearing the doctor title. And 2 female physicians of color reported struggling for acceptance and recognition by patients who sometimes address them as honey and dear. Without a doubt, their experiences support a defensible argument against first-name usage, at least in certain individual circumstances. But for the rest, not one commenter offered any alternative idea other than the obvious and rather vague suggestion of developing better listening skills. Meanwhile, one physician supported the notion of dropping the formal title. Another reported that giving her patients the choice of how to address her yields significant benefits in relationship and trust building. And of a half-dozen nurses and mid-level providers weighing in, only one expressed opposition to elimination of the doctor title, while 2 of the other 5 said that in their observations, patients generally volunteer less information to physicians than to nurses and mid-levels who do not bear the professional designation. So I say, let's go another round on this larger issue of patient silence, shall we? Right here on MedPage Today. But this time, I ask you to include in your comments replies to one or both of 2 questions. First, what's your idea? If patient shyness is conceivably wasting billions in healthcare costs every year, what do you, the experts with the most education and training in healthcare, and professionals with some of the highest public respect, propose to do about it? Second, for those who commented that no reliable evidence exists in favor of dropping the doctor title, can you find the scientific evidence against it? If there is none to date, and instead if someone launched a randomized long-term study in which a number of physicians directed half their patients to call them by their first name and the other half to continue using the doctor appellation, and those patients' health were monitored over time, would you be willing to participate in such a study? Would you be willing to risk a bit of your most trusted and respected status to get to the truth and a possible improvement in healthcare outcomes? Which would take precedence, prestige or patience? I eagerly await your reaction, Doctor.